Thank you so much to the societies and also the moderators for the privilege of presenting today. I have no disclosures except that I currently have an immune-suppressed patient with diverticulitis on service currently, and after preparing this talk, I'm still really not sure what to do, so hopefully I can clear some of this up for the audience. So today we're going to be discussing the prevalence of immune suppression in general, the prevalence of diverticulitis in immune-suppressed populations, presentation of diverticulitis in these groups, overall outcomes for immune-suppressed patients, also surgical outcomes, and then how we make decisions about for these patients. So we know all about diverticulitis. It's increasing in incidence in Western populations, also seen in younger patients. So for immune suppression and diverticulitis, why should we care about this relationship? So it turns out there's increasing indications for transplant and also non-transplant immune suppression, and also there's tons more types of immune suppression that are being developed currently. Immune suppressed patients are living longer, and they pose a challenge in management because their symptoms may be masked, they may have a delay in diagnosis, and they also may have an impaired ability to counteract local or systemic infective sequelae. So previous data has shown that immune-suppressed patients have more severe disease if they present with complicated diverticulitis. They're more frequently having free perforations. They have worse outcomes. The non-operative management is more likely to fail. There's higher mortality if we use medical therapy alone, and also higher mortality if we operate. So great. So there's all the different populations of immune suppression includes patients undergoing solid organ or bone marrow transplant, biologic therapy, those having chronic steroid use, including oral, IV, and even inhaled corticosteroids, patients undergoing chemotherapy, diabetic patients, liver and renal failure patients, as well as patients with cancer or vascular diseases. The incidence of diverticulitis in the immune-suppressed patients are much higher than the general population, 1% versus 0.02%. The range of incidence, anyone from 0.9 to 4%, varies on the type of immune suppression. The incidence of complicated diverticulitis seems to be higher, and the proportion of those patients that progress from diverticulosis to diverticulitis is also higher in immune suppression. These patients also can present differently than immune-competent patients. Clinical manifestations and physical exam may not reflect the severity of what's going on in your patient's abdomen. Signs of infection like fever or tachycardia may be absent or just highly attenuated. Abdominal exams and laboratory values may not be helpful. Although CT scan does seem to be a reliable tool to use to determine the severity of disease. So one study looked at outcomes in immune-suppressed patients being admitted for diverticulitis, and out of 1,100 patients admitted for diverticulitis, 192 patients were deemed to be immune-suppressed. They were divided into 5 groups, and that included patients on chronic steroids, transplant patients, patients with cancer, chronic renal failure, and then other immune suppression. Of this group of immune-suppressed patients, 40% required an emergency surgery. And it was the corticosteroid group that had the highest percentage of needing this. Post-op morbidity or mortality was not different between the type of immune suppressant groups. There was a 28% recurrence after successful non-operative management. Most of these recurred within 1 year, although the majority was mild. However, recurrence did not vary by the type of immune suppression. But it was associated with the severity of disease at that index episode. However, if recurrence did happen, only 7% required emergency surgery for that recurrence. So specifically going into the subpopulations, for patients having steroid use, they had higher rates of perforation. If patients were admitted for a diverticular abscess, they had worse outcomes regardless of the treatment. So if they were drained, if they had antibiotics only or an operation, if they were on steroids, they had worse outcomes. They also had increased recurrence if they had an abscess that was drained. So there have been a handful of studies that looked at possible mechanisms of steroid injury, and this includes steroid-induced atrophy, depleted submucosal lymphoid patches, also the inhibition of a normal inflammatory reaction that could be upregulated by macrophages, increased MMP expression that may lead to more phlegmon and perforation creation, and also some direct colonic injury. So for patients that are undergoing chemotherapy and happen to develop acute diverticulitis, a study in 2014 looked at those receiving chemo within 1 month versus those who did not. Looking at their index episode, these patients did not have more severe disease. They didn't have increased time to resumption of chemo. They had the same failure rates for non-operative management, and they had the same frequency of recurrence as those that did not have chemotherapy over the last 4 weeks. However, if these patients undergoing chemotherapy did have a recurrence, their disease was more severe, they were more likely to require emergency surgery, and they were more likely to be diverted. Perioperative morbidity mortality was not increased in those undergoing chemo, but patients who were having an interval elective resection were more likely to have a postoperative complication. For renal failure patients, a study in 2012 looked at renal failure patients that were waitlisted versus kidney transplant. They had a higher morbidity mortality and more post-op complications after colorectal surgery when compared to patients that have already been transplanted. In 2013, another study looked at kidney transplant, comparing them to the general population. It showed actually that anastomotic leak was equal after elective colectomy between these groups. And then as a side note, if your patient has a peritoneal dialysis catheter, just hope that they don't, because that introduces a whole world of headache. So for renal transplant patients, 0.9% of these patients developed diverticulitis in a study performed recently in 2016. Of these patients, 40% had complicated acute diverticulitis versus only 15 in immunocompetent patients. For renal transplant patients who smoked, were older, diabetic, had polycystic kidney disease, they were more likely to have diverticulosis in general. So this could be one of the explanations for a higher incidence of diverticulitis. However, in this study, a majority of these patients still were successfully treated with non-operative management. For lung and cardiac patients, the incidence, again, is still higher than the general population. It tends to occur early after transplant within the first 2 years. In a retrospective analysis of a prospective database of 430 lung transplant patients, 5% of these patients went on to develop diverticulitis. Less than 50% were uncomplicated but treated successfully without surgery. Although for those who had surgery, 8 had Hartmann's performed, and 3 had a colectomy with a primary anastomosis and diverting ileostomy. However, 2 of those 3 patients actually developed a leak that required a reoperation. For diabetic patients, a great study in 2014 looked at admissions for diverticulitis and found 16% were diabetic. Diabetic patients had higher Hinchy scores and Ambrosetti scores on CT. They had more comorbidities. They were older. However, they were not more likely to fail non-operative management. They didn't have more remissions, and they didn't have more increased mortality. If surgery was performed on these diabetic patients, they were more likely to have renal failure or develop a postoperative complication like an infectious complication. Looking at HIV patients, why this is important now is because with better retroviral therapy, HIV patients are living much longer. So because they're living longer and getting older, their prevalence of diverticulitis is also increasing. So a study in 2016 showed that mortality rate for HIV patients was higher than non-HIV patients admitted for acute diverticulitis. However, overall, that mortality was still lower than when compared to other immune-suppressed groups. They had lower surgical intervention rates, and they had no increased complication after surgery when compared to non-HIV patients. So moving on to overall outcomes, 227 patients with acute diverticulitis were looked at in 2016. 7% of these were considered immune suppressed. These immune suppressed patients had higher rates of complicated diverticulitis, higher rates of emergency surgery, longer stays in the ICU and overall, pulmonary complications, and higher hospital mortality. When looking at surgical outcomes, a NISQUIT study performed very beautifully by one of our moderators, looked in 2016. For emergency surgery, immune-suppressed patients were more likely to have a stoma performed. Laparoscopic surgery was rare, but still it was performed less often if they were immune-suppressed. These patients also were more likely to have at least one major morbidity, higher wound dehiscence, and infectious complications. Most importantly, mortality was 4 times higher for immunosuppressed patients than immunocompetent patients after emergency surgery. Looking at elective operations, immune suppressed did not fare that much better. They still had higher complications like wound dehiscence and major morbidities. However, the mortality rates for both immune suppressed and immunocompetent groups were low, and they were not different between immunosuppressed or immunocompetent patients. Requiring emergency surgery, a 9-year observational study was looked at. 80% of patients were treated non-operatively in this group. 17% were immune suppressed. When they looked at emergency surgery that was required, 46% of the group were considered immune suppressed. These patients had higher peritonitis scores, required Hartmann's more frequently, and had higher mortality, again, which was much different, 26% versus 6% in this group. They did find that when they looked specifically at the patients that did die, most of the deaths did occur in the Hartmann's procedure group, and there were no deaths that occurred in the patients that had resection with a primary anastomosis while diverted. Looking quickly at recurrence, a study in 2016 showed no difference of recurrence after successful non-operative treatment between immune-suppressed patients and immunocompetent. For immune-suppressed patients, again, it's the same story. They had required more emergency surgery at their index episode. More had Hartmann's performed. There was higher grades of peritonitis. However, again, they did not require emergency surgery for recurrence any more than immunocompetent patients. And for elective surgeries, there was no difference in mortality and no difference in length of stay. For immune-suppressed patients, if they had a severe first episode, they had higher recurrence, their recurrence was more severe, but again, they weren't more likely to require surgery for the recurrence. And again, for these immune-suppressed patients, they had higher recurrence in the first 6 months, and they were also more likely to recur within these 6 months if their index case was much more severe. So how do we decide what to do for these patients? ASCRS in 2014 put out the most recent practice parameters, showing that we should have a very low threshold to operate for patients with immune suppression during their first initial hospitalization. So putting this all together, at presentation, we should establish the correct diagnosis and start treatment promptly. CT scan is the best tool to guide our treatment, and non-operative management could be feasible when uncomplicated. However, we should all beware if it's complicated or severe disease, because immune-suppressed patients have higher severity of disease, they require emergency surgery more often, and they have higher mortality at the initial episode. It is also important for us to identify risk factors that predict more severe disease at the index episode or for recurrence. So transplanted patients fare better overall than patients that have renal failure or liver failure. HIV patients have higher mortality for acute diverticulitis than the general population, but it's still not as bad as other types of immune suppression. And patients who are administered or have chronic steroid use seem to have worse outcomes across the board compared to other patients with immune suppression. So for surgery, emergency surgery will always be worse for patients that are immune suppressed. However, we still have to have a low threshold. If a patient needs an operation, we shouldn't delay because they're immune suppressed. Several studies that have looked at elective surgery more recently show really equivocal outcomes. So more recent studies show equal outcomes for immune suppressed versus immunocompetent patients. However, other studies show increased morbidity for elective operations, such as patients undergoing chemotherapy. Type of surgery, one study did show that resection with primary anastomosis and diverting ileostomy may be safe for immune suppressed patients even in the emergency setting. However, Hartmann's procedure still may be considered safer, as seen in a study that looked at lung transplant patients. So finally, if we get away with treating our patient non-operatively for acute diverticulitis if they're immune suppressed and we get them out of the hospital, we should consider elective surgery for those that are at the highest risk for recurrence. This should be determined by how severe their index presentation was, and we should try to operate them within 6 months since that's the most likely time they would recur. We know this because we want to prevent recurrence in this group because recurrence can be more severe and have worse outcomes. But finally, we know we have to balance these recommendations with the complications that can occur in immune-suppressed patients after elective resection. Thank you so much for your attention.